And I'd now like to welcome Dr. MacMinn. I'll give a short introduction, and then I will ask Ethan to share his slides and get started. So, Ethan MacMinn is trained as both a sexual health and an infectious diseases physician and works at Gold Coast Sexual Health. He's a representative on the Australasian chapter of the Sexual Health Medicine Board. He has a keen interest in HIV medicine, particularly management of complex resistance and then simplification of anti-retroviral regimens. And so Ethan's going to talk to us today about long-acting antiretrovirals in both treatment of HIV and in HIV prophylaxis.
Thank you for inviting me to speak, and thank you all for attending today. I've called this presentation a Cook's Tour, really because there is a lot going on in this space from a long-acting treatment perspective, both in the forms of regimens for HIV as well as PrEP. And this talk could easily be an hour and still potentially not cover everything in terms of agents and what studies are being done currently in this area. So I'm broadcasting to you from the Gold Coast, so the lands of the Kumbrumeri people, of the Ugambi-speaking people. And I'd like to acknowledge elders past and present, and any Aboriginal or Torres Strait Islander people who may be tuning in today. There we go. I do have one disclosure. That's it there. I'm going to start by talking about what we have potentially available in terms of what's TGA approved, and then go into, as time goes on, what is currently being investigated. So the first agent that we have, the main one that's available currently, is cabotegravir and rilpivirine, which is known as Cabenuva. It's a combination of an integrase inhibitor and an NNRTI, given at injections of 0 months, a month later, and then every 2 months. It's been on the PBS now for 4 years. Factors that increase risk of failure include archived mutations to NNRTIs, particularly ones that relate to rilpivirine. HIV subtype A6 is one that is associated with an increased risk of failure. Previously, it's been both A1 and A6. However, there's been subsequent studies that have been done recently, which has found that subtype A1 isn't associated with an increased risk of failure. A BMI over 30 is a risk. However, this can potentially be overcome by using a longer needle. The medications are given either by ventrogluteal or dorsogluteal injection. Previously, the manufacturer had recommended only using ventrogluteal injections, which can be a little bit difficult given some patient factors and patient preference factors. However, there's been some fairly recent studies looking or comparing both of the injection methods and finding not particularly much of a difference in terms of drug level in muscle or outcomes. In terms of adverse effects, one of the main ones is injection site reactions. The other thing to be aware of is that rilpivirine, in combination with other medications, can contribute to QT prolongation. And so, much with any other antiretroviral regimen, we need to be considerate of potential drug-drug interactions. Now, I've mentioned 65% in injection site reactions. That's incorrect for this agent. It's actually for a different one, which I'll cover shortly. Cabotegravir has also been studied and utilized as PrEP. It was TGA approved in 2022, but is not currently listed on the PBS, and because there's been disagreements between the PBAC and the manufacturer in terms of agreement on a price. There's been 2 multi-site randomized control trials, HPTN 083 and 084, which have showed superiority in comparison with oral PrEP in both cisgender women as well as men who have sex with men and trans women. As opposed to Cabenuva, where the rilpivirine component needs to be refrigerated in order to maintain its stability. Cabotegravir by itself is stable at room temperature, which makes it a lot easier for people that are potentially traveling or who may not necessarily be able to, or situations where people may not be able to have continually refrigerated medications. For cabotegravir, there's no dosage adjustment that's required in renal impairment, which is quite useful, particularly because one of the big limiting factors for tablet-based tenofovir and emtricitabine-based PrEP is that it's not recommended in people with moderate to severe renal disease. One factor with cabotegravir PrEP is because it's an integrase inhibitor. If it's being used, you need to keep quite a significant watch on HIV seroconversion because people may have weakly positive results. And so Australian and international guidelines recommend that in people who are using cabotegravir as PrEP, that they should have HIV viral load monitoring in order to, in addition to current antigen antibody tests, in order to be able to be aware of HIV acquisition as soon as possible. The manufacturer did have a compassionate access program that they introduced last year. In Australia, they were going to fund 100 people who were not otherwise able to have tablet-based PrEP, and that got subscribed and filled within weeks. And it's currently, I believe, oversubscribed. Lenacapavir is a novel agent. It's a capsid inhibitor. It's first in its class, and you can see on the diagram there that it has action at multiple stages of the HIV life cycle. It was TGA approved in December last year, but it is not PBS listed. It's given as a 6-monthly subcutaneous injection. If using for HIV management, then it needs to be used in combination with other agents. Its indication as therapy is for treatment-experienced people with multi-drug resistant HIV where other treatments cannot be used. Despite this, there has been some compassionate access that has been given in situations where there have been significant drug resistance. However, I put in an application recently and was told that there's none being given out at this point in time. Where lenacapavir has a lot of interest as a treatment therapy, but especially when there's going to be another agent with another long-acting agent that will be able to be used to pair with it. But it also has quite a lot of steam generated in terms of as a PrEP agent. So there's 2 fairly large randomized control trials looking at using lenacapavir as PrEP. So Purpose 1 was based out of Uganda and South Africa with about 5,000 plus cisgender women, where there was a combination of, or there was a double-blinded study where they randomized people into either the lenacapavir as a subcutaneous injection to tenofovir alafenamide and emtricitabine, or tenofovir disoproxil and emtricitabine, which you may note one of those is a subcutaneous injection, the other 2 are tablets. And so they gave a dummy of the agent that they weren't given. There was 0 transmissions of HIV in the lenacapavir group of this trial. And I've got some if we go to the next slide, purpose 1 is on the left, and you can see that no transmissions. However, the transmissions in the oral tablet group were quite high in comparison. And when they did some blood testing levels, looking at levels of the agents, it was suggestive that the oral medications weren't being taken as well, particularly well. However, still 0 transmissions in 2,000 people using lenacapavir is still quite impressive. And you can see the results there similarly for purpose 2, which was a study of several 3,000 odd people from the United States, Latin America, Brazil, South Africa, and Thailand, who were men who had sex with men, or trans women, trans men, or non-binary people who have sex with people assigned male at birth. And so you can see 2 transmissions in that group is still quite impressive. I believe that a PBAC application has been submitted for lenacapavir to be used as a PrEP agent. In terms of the pipeline and what's being studied currently and may be available in the future, there's also a lot going on there. So I'll talk first with the drugs that have a name, and then as we go through what's available will kind of be things that are in a more phase 2 study area. So we've got islatravir and lenacapavir. So these are 2 novel agents. Lenacapavir being the capsid inhibitor that we've talked about previously, as well as islatravir, which is a nucleoside reverse transcriptase translocation inhibitor, or an RTI, as opposed to NRTIs and NRTIs. Islatravir has been trialled in a few different settings. However, some of those trials have been halted due to reduced CD4 and white cell, particularly lymphocyte counts in patients who were participating in those studies. However, they've decreased the dosage of the islatravir, and that hasn't been a particular issue that's been found in subsequent studies. So there's a phase 2 study that's been reported at CROI this year, up to 96 weeks, where 106 participants have been randomized into either islatravir or Biktarvy for 48 weeks. And then for the 48 weeks subsequent to that, both groups were continued on islatravir and lenacapavir as a weekly tablet. There were no viral loads in either group where viral load grew above 50, and there were no grade 3 or higher adverse effects. There are phase 3 studies that are currently ongoing that have yet to be reported in full. The phase 3 studies, one is a double-blinded RCT and the other is an open-label one. We've got letivibart, and over the last few years, there's been a lot of work in a broadly neutralizing antibody space. So using a number of antibodies against the HIV proteins. Most of them are geared towards the clade B virus, which is the predominant virus in the United States as well as Australia. In this study done by the manufacturer, they've paired it with cabotegravir, and what they've done is they've trialed it with either with the letivibart either as an intravenous medication or as a subcutaneous injection combined with a recombinant human hyaluronidase, which is able to assist its or reduce its speed of absorption. And so you can see in a very small trial, somewhat similar results to oral standard of care, but that will require more more robust studies, let's just say. Then there's a couple of third generation integrase inhibitors. So things like dolutegravir and bictegravir are considered second generation instis. And they really changed the game in terms of their barrier to resistance. The third generation integrase inhibitors are thought to have even greater barriers to resistance than these. So you can see this is data from the manufacturer that looks at fold changes in the EC50, which is the amount of medication that you need in order to kill 50% of the virus. And so they've taken a bunch of virus that they've got on ice with various mutations and measured the EC50 and compared it to older integrase inhibitors there. This has only been through phase 2A trials looking at virological response in ART-naive patients over the course of 10 days in 22 participants. So a fair way to go in terms of this agent. VH499 is another capsid inhibitor that differs itself from lenacapavir in the sense that it does not inhibit or induce CYP3A4. So one of the drawbacks of lenacapavir is that it does have that interaction with other medications that are metabolized by CYP3A4. So key ones of those are the DOACs and carbamazepine and rifampicin, which, depending on patient factors, may be of particular concern. But a long way to go in this with this agent because it's only had one phase 1 study. And then what I'm going to end on today is GS3242. This is a novel long-acting integrase inhibitor that only has phase 1 data suggesting a dosing interval of at least 4 months. It's going to start phase 2 trials this year. So what I have to end on is that we've got there's very interesting places to go, both in a HIV prevention, but also in a HIV treatment. From an HIV treatment perspective, there's going to be a lot happening, particularly with novel agents, and that will be very helpful for people, particularly a lot of our long surviving patients who have multiple issues with resistance, who still require multi-tablet regimens in order to maintain virological suppression, and particularly if there is a way of making PrEP widely available throughout everywhere in the world where it's needed. Some of the agents that we've got available for PrEP will also be extremely helpful and extremely useful at preventing HIV transmission. And thank you all for your time.
Thanks so much, Ethan. It's a really wonderful talk, and it's great to be at this somewhat revolutionary time in rolling out PrEP to more and more people who are eligible for it, and also transitioning our patients who are so used to having daily medications onto longer acting medications. Even with the relative discomfort of having an injection, the rates of people who are choosing to have long-acting injected medications is just super high. We're right on time for proceeding with the next talk. So I know that there'll be some excitement for questions, and I hope, Ethan, you're able to stay around to help us out. The next two speakers will also be fantastic.